into electronic medical records, because psychiatry is still so small potatoes compared to all of med-surg, that the companies that make these medical records, either they don't work and they go broke and you can't do anything with it, or they don't communicate with the med-surg people. So we have a huge problem with that right now. The other problem, which is somewhat I think would be unique to psychiatry, is patient confidentiality. And so we cannot share information without the patient permission. And occasionally there are patients that don't want those things shared, so it's a real problem.
Well, we're looking at ways to try to address that with the CoreNet, electronic medical records, and ways that we can improve clinical trials and also modeling clinical trials before you actually do the trial to make it more efficient and increase efficacy that way.
Yeah, that technology is critical if we get it in
Yeah.
place. That will make a huge difference. So real quickly, this is also the STAR-D trial, which for us in psychiatry is like the mecca trials for antidepressants. So this is about 10 years old now, but this is done by National Institutes of Mental Health. It wasn't funded by pharma. And it's looking at 3,000 some patients. The thing that's interesting about this, it's a very naturalistic study. They're looking at people in primary care settings, psychiatric settings, and these are people who are not excluded because of criteria. Some of these people are using drugs. Some of these people have comorbid medical conditions. They're just in naturalistic settings with their providers giving them medication. And for purposes of our discussion today, it's real fortunate for two reasons, this study, which is 10 years old. First reason being is that the drug that everybody, these 3,000 people started on, was citalopram, right, which is the one that we said the American Heart Association is first line as well as sertraline. So that's interesting. And what they did is people were all started with citalopram, and then if they failed citalopram, they did not go into full remission, and they were switched to other antidepressants, what we call augment. We added either bupropion or buspirone or cognitive therapy. If they failed this, then they were switched to other antidepressant medications, specifically venlafaxine, bupropion. And then if they failed that, then they went to mirtazapine or nortriptyline or augmented. So lithium and thyroid supplementation are particularly back then more common augmenters. And then finally, if they failed that, they went to an MAOI or they went to mirtazapine and venlafaxine. There's a famous psychopharmacologist in the nation who likes to call mirtazapine and venlafaxine California rocket fuel. Multiple systems and really zapping the patient. So the unfortunate use, which is sorry to say, people treated with citalopram, only 32% went into remission. And this is not good. This is remission rates. If you look at response rates, it's about 50%. But in terms of full remission is what is the gold standard, only 32%. By the time they're switched to level 2, again, it's about 30%. So if you do the statistics, it comes out to about 50–55% of people responded to combination of level 1 or level 2. Then it gets worse and worse as you go down to this complexity of pharmacological treatment. So that's something that we are continuing to work on and using different strategies other than just medications. But the point of this study, because I don't expect anybody, I don't think many people in here are going to be using MAOIs or combining all these different things. But the 3 points that are very important for our discussion today is, number one, citalopram was the drug that was used because, again, it's well tolerated and shown to be effective. The second thing that's interesting in this study, if you look at the study, is this study, they were on level 1 for 14 weeks. And if you look at people who are going into remission, about half the people went into remission. Now we tell people antidepressants are going to take a week, 2 weeks, 3 weeks, 4 weeks, you can get down for at least 6 weeks. But in this study, half the people went into remission took them between 6 weeks and 12 weeks. Okay? So particularly dealing with systems, sometimes it's hard to get your patient to see a mental health professional or psychiatrist. You may be stuck with them for a while. But there is data, if you can hang in there longer, that you get a higher remission rate. So 6 to 12 weeks, some people, half the patients go into remission. The second thing, which was fascinating to us, which was quite unexpected, which is relevant here, is in level 2, you're switching to these different antidepressant medications. Some of these work on different mechanisms of action, and but what here is sertraline. So we were always taught in medical school, and we still think if a person doesn't respond to one antidepressant, switch to another antidepressant that has a different mechanism of action. But with what this study showed us, So it didn't make any difference if he switched to sertraline or he went to something different like venlafaxine. Their remission rates were the same. So if, say, you're doing first-line citalopram, person isn't responding, it's okay and reasonable from a standpoint of the literature here to go to sertraline. And some people say you should go to a different class of antidepressant, but in this study, people did just as well sertraline as being to a different mechanism of action class. Third thing is that once you get down here, not only the people who go into remission down here, they have a higher rate of recurrences. So as people get sicker, have more difficulty, even when you see them and they're doing okay with that antidepressant, kind of monitor them closely because they have a much higher rate of recurrences. So real quickly here, these are just some of the other basic antidepressants. Go over quickly, and I'll try to point out the parts that may be relevant to you. Fluoxetine, we still use a lot of it today. It has the longest half-life, so once you take it, stop it, it takes 4 to 5 weeks to clear out of the system. So talking about withdrawal symptoms, Prozac, fluoxetine was the first SSRI we had. Nobody had withdrawals from Prozac just because of metabolism. The half-life was so long and they had an active metabolite there. Sertraline here we talked about, again, one of the first-line medications you want to think about. Must be given with food to increase bioavailability. Pretty well tolerated. Most common side effects is gastrointestinal, nausea, upset stomach, diarrhea. Paroxetine, another SSRI, but again, this is the worst in terms of anticholinergic side effects. So things like weight gain, sexual side effects, also in terms of drug-drug interactions and withdrawal symptoms. So something I would not think of too highly in terms of patient population. And again, citalopram we talked about, and then there's escitalopram. So citalopram is made up of 2 isomers and 2 enantiomers. And the one enantiomer was taken out, and it's escitalopram. And it's the one that has the potency and activity that you want in terms of helping depression. And the other enantiomer had all the negative side effects. So citalopram is 50% escitalopram. So consideration also is escitalopram because it is a little bit more tolerable in terms of side effects.
What is SE on that prior screen under Celexa? What does SE mean?
Sorry, side effects.
Side effects, okay.
Yeah. Both of them are very well tolerated in terms of side effect profiles. And escitalopram probably has the lowest amount of drug-drug interactions also, which is pertinent for a lot of these patients. Wellbutrin, it's good antidepressant. We also use it for smoking cessation, but it's very activating. It doesn't have sexual side effects, doesn't have weight gain, but it's activating. So if you have a cardiac patient, diabetic patient who's pretty anxious, this actually will make them more anxious. And it also increases the risk of seizures if used at higher dosages. Mirtazapine, good antidepressant, but its 2 main side effects is sedation and weight gain. So again, if you're concerned about weight gain with your patients, it's something to think about. Effexor, now I'm moving into the SNRIs, the serotonin norepinephrine reuptake inhibitors. The noradrenergic stimulation, unfortunately, has a tendency to cause increase in cardiovascular issues, and so you have to monitor blood pressures with venlafaxine. Again, it's problematic in your patient population. And Cymbalta is approved for MDD, diabetic peripheral neuropathy, fibromyalgia, as well as generalized anxiety and chronic musculoskeletal pain now. Vibrant is one of the new ones. It has a new mechanism of action. It hits 5-HT1A. It has no effect on blood pressure, heart rate, or EKG parameters. I haven't seen any studies on this yet, specifically in terms of post-MI patients, but at least in the non-cardiac patients, it seems not to be having any cardiovascular effects. Fetsima, levominastopram, also is an SNRI, and there is some increased rate of tachycardia, so again, not something you want to think about possibly being problematic. And the newest, latest antidepressant is vortioxetine. Vortioxetine is interesting in terms of, at the time of launch by the FDA, there was a registration trial specifically for the geriatric population. So it's shown to be safe and effective for people over 65. So that's something to think about in our patient population. Also, it's the only antidepressant which in Europe now has an indication for cognitive improvement for those with major depressive illness. FDA here in the States are still sort of toying with that idea. They didn't pass it first time through, but there's specific thoughts. The World Health Organization classifies this as others. It's not only hitting serotonin reuptake, but it's hitting 5 serotonin subreceptors, which are affecting acetylcholine, glutamate, so it may have some specific cognitive improvement advantage. So again, there are other certainly non-pharmacological interventions to think about. The sort of newest thing we've had in recent years is transcranial magnetic stimulation. So if we gave this talk 20, 30 years from now, it'd probably be a completely different talk. And I'm sure we'll have medications for those pharmacists here. But there'll probably be a lot of other treatments that we have that is hitting neuromodulation, that's tweaking the neurotransmitter, that's hitting the circuitry system without just using medications for it. So, we have more deep brain stimulation, cortical stimulation we're looking at. Transcranial magnetic stimulation is something we're looking at in terms of trying to put in magnetic fields like MRI to tweak the neural circuits to help with depression, for treatment-refractory depression. We still have ECT. And all the therapies, including cognitive behavioral therapy, certainly and I can't emphasize this enough, we didn't talk about that, but the non-pharmacological psychotherapies are critical in terms of people with serious medical illnesses, cardiac illness and diabetes. Psychoeducation is key. Cardiac rehab is critical. Again, collaborative care. And so the purpose of all these, again, is to get the depression under control, but also to improve the outcomes for the glycemic control and cardiovascular outcomes. So take-home points. Depression is a very common comorbidity, which we talked about, and it results in worse clinical outcomes. So they should be really routinely screened for depression and suicidality. And the PHQ-2 and 9 are really the standards in the community that everybody's using these days in order to screen for depression and use it again for monitoring and follow-up. So you want to treat and monitor both. You want to get the depression in remission, but also help with the glycemic control and cardiovascular issues. And collaborative treatment is the most effective with coordination of care between all the different healthcare providers. And again, this again reiterates what the American Heart Association is doing, so we went over that, is screen, subdivide your patients, treat them appropriately based on their level of severity. You want to screen for suicidality, and then you got to monitor for improvement and watch for adherence and physical improvement as well as psychiatric improvement. So conclusions, then we can have more discussion. And depression is a very common and modifiable risk factor for cardiovascular disease and diabetes. It's very common, it's very modifiable, so there's things we can do about it. And so the key is screening and treatment, and that can have significant positive impact for the course of both these illnesses. So at our hospital, we treat a lot of college students, and it's very important that college students with major medical psychiatric illnesses are going on, you can change the trajectory of the illness. Right? If they're diabetic or they have major depression, the complications from those illnesses, you can change the whole trajectory of the illness. I think we have to work together in collaboration on these patients have these comorbidities. Okay, so questions?
Thank you.
Discussion, yes?
My question about JET7 for anxiety patients. As we know, cardiac...
Could you say who you are, please?
Excuse me?
Just state your name and your organization.
Oh, my name is Amy. I'm from All Inclusive Community Health Center. And my question about the JET7 screening tool that we are using for the patients specifically for coronary artery disease, because we know they are kind of type A personality, they are high in emotions and everything. So what do you think about JET7?
To be honest with you, I'm not that familiar with JET7.
You're not? It's
No.
more kind of anxiety screening tool that we use in a clinic. When there are questions about depression, is more towards that patient, maybe it's more anxious and maybe it's more anxiety and panics and stuff like that. It's exactly the same question, same type of questionnaire. Yeah, it's PHQ-9.
Yeah.
A little bit more the emphasis on anxiety.
Yeah, so the good news, or the couple of comments. So, we talked mainly about depression today, but it's a little bit focused. So particularly cardiovascular disease, the other thing you're really looking at is depression, anxiety, post-traumatic stress for those who've had things like MIs. And all that sort of got taken together. And part of the problem with some of these studies is they're looking at mainly just major depression. There's other these major factors like anxiety, which probably plays into it, which is why some of these studies don't have sort of perfect outcomes that show things. So that's very, very good to screen for the anxiety. And good news, again, there's specific DSM-5 criteria for generalized anxiety disorder or different anxiety disorders. And you know, from a brain circuitry standpoint, there's a lot of interconnection there. So certain antidepressants are used both for just depression or just anxiety, or if they're used for both. So the SSRIs specifically, some of them are FDA approved for both, some are not, but basically all of them help people with just generalized anxiety disorder, as well as those with just major depression, or a lot of these people with both. Also, a lot of these SSRIs equally work for post-traumatic stress disorder. So again, in many ways, it's, you know, patient comes in, you can't tell if they're just depressed or anxious or both. You hit them into the SSRI, at least you're hitting both those factors. Yes.
Dr. Suzuki, you mentioned cardiac rehab. So are there studies that shows that cardiac rehab help with the depression or?
There is specific studies that, yeah. So cardiac rehab, you know more about the cardiac research, but clearly shows improvements in depression too. For things like, gives patients that structure they have to go, gives them social interactions, gives them some motivation and goals to shoot for. So there are specific studies showing that.
What about the use of these antidepressants in dementia patients?
That's tough. Dementia, we still don't have a good understanding of most of these dementias and how to treat. But one thing that certainly we miss all the time, which we really need to get better at, just like in these other forms, is there's a lot of people who are pseudo-dementia. So they look like they're totally demented, but it's really they're having cognitive impairment because of their depression. And so you identify that, you treat them with an antidepressant, and they all of a sudden look like you and I. The cognitive impairment is because of the depression. So that gets missed, unfortunately, all the time. And if you use the wrong antidepressants, those that say anticholinergic side effects, you make that confusion worse. So you use specific antidepressants. So for example, vortioxetine, that last one, which has specific cognitive improvements and attention span, memory, processing speed, executive functioning, new medication like that might be able to treat more effectively geriatric depression and help their cognition also. That's a good point.
Thank you.
Yes.
Thank you, that was fantastic. I have a couple of questions. One is relating to the other people that have asked about exercise. I was thinking more in that we're interested in prevention here, so using exercise for prevention of depression and cardiac disease, so sort of really doubling the impact of it when you tell patients about this.
Yeah, so things like exercise, in terms of prevention, particularly those people who have been had prior depressive episodes or maybe genetically predisposed to get depressed, and have a major life stressor, an acute medical illness, something else happens. Yeah, all those different things before you get to the point of medication, in terms of healthy lifestyle, in terms of exercise, eating healthy, social interactions, all that is critical. The difficulty is once they sort of cross the line where their functioning is impaired, because they have all these other things like exercise and such are helpful to get them out of it. They need the medication and combination. But the key, like you're saying, is to try to get it early, start treating aggressively with non-pharmacological means so they don't have to get to this point.
Thank you. The other comment I had was a little bit about our wonderful patient representative. I was actually thinking about women. We know cardiovascular disease is underdiagnosed in women, and is that because the depression, anxiety bit is overestimated, perhaps? That the overlap there.
Yeah, no, that's a very good point, and I think it is because we see it. And I think probably speaks to the fact that we in psychiatry, particularly when people have more generalized anxiety problems, some of that mimics cardiac type symptomatology. And we probably need to be more sensitive to be aware of those cardiac risk factors and symptoms and get them to their primary care cardiologist here. That's a very good point. Okay, it reminded me to say something very else, some point that's very important about, I don't know why I triggered it, but in terms of antidepressant medications, the highest risk factor for people who commit suicide are males over 75. So that's a very important thing to look for. But secondly, all these antidepressants, and you see TV commercials for antidepressants all the time, they all have the exact same warning, which scares the bejeebies out of patients, which is taking this antidepressant can lead to increased suicides and behavior. And that's a standard FDA warning. So you get the patient to ask you that all the time. But the critical thing to know is there are no studies that show that antidepressants increase suicides. So part of that increased suicide thoughts and behaviors related to maybe misdiagnosis, they're really bipolar, and they're you cause them to cycle and such, or misdiagnosis. But antidepressants, when they ask you about taking antidepressants, are fearful of that, because it says it could lead to suicides. It does not lead to suicide. It increases the suicidal thoughts and behaviors around suicide.
Could you talk about another non-pharmacology-oriented aspect to psychology for cardiovascular and diabetes patients, and that is brain training, meditation, mindfulness training?
Yeah.
How important is that?
Yeah, now this whole started about cardiovascular disease and psychiatry started with this type A personality literature, and all that's related to stress. And so things like the sort of the next evolution in psychotherapy is things like mindfulness, being in the present, and those things really do decrease stress levels, and I think that really does decrease a lot of the cardiovascular risk. So again, exercise, and stress is either external or internal. So you get stress from having had an MI, but you also get stress from relationship problems, problems with the boss, all these other conflicts. And so the more you have some therapy to learn how to deal with external stressors and internal conflicts more effectively, that does decrease a lot of things going on that's going to increase your cardiovascular risk. And a lot of these things, like with diabetes, it's thought that increased external stress, how you deal with it, causes increase in cortisol, increase in intra-abdominal fat, increases metabolic syndrome. So doing these other non-pharmacological means to decrease that stress reaction can be very, very helpful. So there's a whole mode of different therapies out there: cognitive behavioral, more analytical, dynamic, mindfulness. Yeah.
Dr. Gonzalez has a question.
Yeah, have there been any studies in patients who get started on an antidepressant to see how long they remain on the antidepressant?
So the question is, how long do they remain on antidepressants?
Right, so they may be ready to be weaned as far as they're not really depressed. It's been more than 6 months.
Yeah. So all the bodies, the APA, everybody, it's very, very clear cut. So we have studies of people who were depressions prior to we had antidepressants in the 50s and before. And major depression tends to have this very slow course coming up, lasts for a very long time, and then tends to kick out a period of months and months and months. So the purpose of antidepressants is twofold. Number one is to get them out of that depression, but secondly, and equally important, is to keep them from going back into depression. So if you look at those studies from the 1950s and before, just about 50% of people who have one major depression have recurrent depressive episodes. It tends to be for about half the population recurrent illness. And so that's where it becomes all about collaborating with your patient. Gee, this is your second major depressive episode. The last time you stayed on for 6 months, but then you got depressed 2 or 3 years later. This tends to be a chronic medical illness for some patients. And so some of the people need to take antidepressants long term, not because you're doing anything wrong, and not because you haven't worked through things in therapy, but for some people just biologically recurrent illness. And so you might want to consider staying on antidepressant long term, and let's talk about the long-term side effects of this medication. Most of these antidepressants do not have long-term side effects compared to things like antipsychotics, let's say. So you have to weigh out the benefits versus the risks. Or if you have a person with one major depressive episode, and they come to my hospital, and they were psychotic at the time, they had a very serious suicide attempt, they had a genetic family history of major depressive illness. After one episode, I'll have that discussion with the patient. Well, gee, you've gotten over this, it's been 6 to 8 months, you're doing well, but we have to decide, you and I, whether you want to stay on this long term, because one episode can destroy your life. And if you want to stay on it, then we discuss the different factors, plus and minus. So it's very much individualized to the individual patient, genetic family history, planetary stress levels. So again, minimum 6 months, but that can be extended, but 6 months is really the minimum. All the studies, that Kupfer curve we saw, is based on looking at people who had stopped their antidepressants before 6 months, then having a recurrence. And you like I, and it's very good for health insurance companies. They send us those letters when, gee, your patient only filled their second antidepressant, and what happened? And if you look at the studies, patients, particularly psychiatric medications, they tend not to take it for these periods they should. So it's really about education and learning what might happen if they stop prematurely.
Hi.
Question.
Yeah, I'm Kelly Green from Kaiser Permanente. I'm just wondering if you have thoughts about how community pharmacy can be involved in addressing depression as a comorbid condition, especially as they're doing MTM therapy and so forth.
Yeah. So again, like the American Heart Association is saying, is sort of all levels of interaction with the patient really should be involved in the screening process, involved in education. So, to be honest, I'm a little bit ignorant about what goes on in pharmacies, so I guess it shows my ignorance. But it probably relates to the fact that we need more education, because I'm sure there's more that pharmacies can do in the community, be it screening or if they identify the patients on an antidepressant plus on cardiac medication, that should put out some bells and whistles. Again, the problem is that whole confidentiality issue with psychiatry, and you need to get patients' permission to release any type of psychiatric information. So that's problematic.
Steve's got
I'll come up really briefly and hand it over to Lawrence. I think he has some comments on this as well. But this is an area that pharmacy is getting much into. We've had pharmacy integrated into medical clinics and Kaisers or VAs, and there they provide a wide variety of services, everything from primary care to behavioral health. For example, Drew is both a primary care and behavioral health trained pharmacist. So we've had that model for a long time. But we know that, especially with the recent provider status law here in California, that much of this needs to move into the community pharmacy environment in order for solo and small group practitioners to have access to these services. So there's a big push now. I know Rouse is one of the leaders in terms of chain drugstores that are doing more screenings, more medication management. I can honestly say, though, I don't know how much of that relates to behavioral health. And I know that on our end, we're trying to push for some of the low-hanging fruit in behavioral health, some of the adherence, but we know the limitation is the patient health information, being able to exchange and share that information. So I toss it back to Lord and see if he has any things that he's been doing in this area.
Yes, that's definitely something that we've been aware of, and we have incorporated tools like Page 2 and 9 for some of our programs, such as our diabetes coaching programs, because we realize that there are comorbid factors with these different disease states. So we do have that. The ability to share that information, as you said, is a problem. And generally, we can refer, but we don't disclose it without the patient being able to tell us that we can. But it is something that we always try to incorporate. It's something that we're aware of, and even new programs that we're developing, like we're doing a transitions of care for patients coming out from the hospital to the community or whatnot. That's something that we also do now from the perspective of improving care, because we also get not only physical medical providers involved, but also people like case management involved, because they want to know things like that. So those are things that we also have incorporated, because we understand that there is a need for it.
Yeah, sort of a strange foothold in that too, which could sort of open the gates a little bit. Is one of the big things in we're doing in psychiatry these days and pushing is long-acting injectable antipsychotics, which are critical. And most of us in more private practice aren't going to be injecting our patients. It's not good to touch patients or have that type of involvement. We don't have capacity to inject them. So I know a lot of pharmacies are setting up places where they can be injecting antipsychotic medications. So that's a very big need for psychiatrists to have. I think that might be an opening to expand in other ways.
I think one final question, I think maybe.
Dr. Cassidy Say.
Sorry, I know this is a little off left field, but I have a silly question. In the world of medicine, when a PCP sends it to a specialist is common courtesy to ask who did you refer, and ask who to get the information back. I know in the world of parity right now with psychiatry and psychology, there is no referral because the patient actually will go his or her own. But is there a common practice in your world that actually asks who is your primary care physician?
Yeah, so I think it's variable, but certainly that is critical. So typically, like in my group practice, if the primary care is referring the patient in, see the patient, then typically I'll call the referral source back and have some little bit of discussion with them. I know, like in a psychiatric hospital setting, the Joint Commission standards regarding having to send the paperwork to the next referral source, but usually that's another psychiatrist, but occasionally it's a primary care type setting.
I can tell you for a fact that most of the primary care doctors that even they refer, most of them do not send any information back. When they do ask for information, there's that brick wall. It's not a paper, it's a brick wall that's probably 10 feet deep. They said, and the front office staff said, no, we will not send you any information until they referred, because they've hide behind HIPAA. even though patients say that to the primary care doc, that they sign all the release form that they need to, a lot of times there is that disconnect.
The reason why often I'll call as opposed to send my records is because there's